Hello, welcome to new question. And in this question, I will explain about infective endocarditis organism and new updates. Okay, as there was a question about old updates, I hope we have to follow this new update thing. Okay, so in the infective organism, endocarditis, the organism for the native wall endocarditis is the in the community acquired thing is streptococcus, but in the hospital or healthcare associated infection, you have to go with staphylococcus. For the prosthetic wall in the month 0 to 12, both remember both. You have to remember the cons means Coagulase negative staphylococcus, and for the 12-month part, we have to go with Streptococcus viridans. For the TAVR or TAVI is a procedure for which you have to go with Enterococcus more than Staph, and with cardiovascular implantable electronic device, you have to go with Staph. For the IV drug abuser, right sided first, you have to go with MRSA, and there are some more with left-sided endocarditis. You have to go with Enterococcus and Pseudomonas and Candida. So the most important is this one for more than 12 months is Streptococcus viridans, prosthetic valve. There are updated guideline for the infective endocarditis. That guideline is known as important. This is the Duke criteria. You have to remember this. And in the Duke criteria, for the definite diagnosis, either you have to go with the pathological criteria or you have to go with the clinical criteria. Okay, in the pathological criteria, there are 2 points, and you have to remember it by heart. There is no trick. And I saw that there was no question till now in the pathological criteria and is recently added. But the clinical criteria is important. For the clinical criteria, you have to consider that either two major or one major plus three minor or five minor is the possible definite diagnosis of infective endocarditis. Okay. The important points I highlighted here, the three important things in the major criteria are the microbiological criteria, the imaging criteria, and the surgical criteria. Okay, you have to remember it by heart by the trick MIS. Okay, the microbiological criteria you have to go for the positive blood culture. Okay, can meet if one of the following condition is satisfied: either the isolation of commonly occurring microorganism with two or more separated blood culture set, or rarely causing infection from three or more separate blood culture. Okay. For the lab test, you have to go with PCR for the Coxella, Bartonella, Trophirium Whipple from blood. These or the Coxella bonity with IgG antibody titer more than 1 ratio 800, or indirect IFA showing IgM or IgG antibody to Bartman Hensley or Bartonella more than 1 into 800, 1 ratio 800. For the imaging, the preferred is transesophageal echo, TE, transesophageal and echo is preferred. Okay, and there is also cardiac CT is there. As in the cardiac CT, the paravalvular lesion is not seen in echo. That's why the CT is included in this paravalvular, around the valve wall. The lesions are not seen. That's why we included, or these guidelines included, CT scan. There is also FDG PET CT imaging. The important thing is just remember this, the FDG PET CT imaging, they included more than 3 months of criteria. Means if patient have more than 3 months of history of more than 3 months of cardiac surgery and echocardiography is inconclusive, you have to go with FDG PET CT in the prosthetic wall endocarditis imaging के अंदर. And for the surgical intraoperative evidence of eye that someone is doing the surgery and you are finding vegetation abscesses, then you will go with this. For the minor criteria, mm, the predisposition to the infective endocarditis like the previous history, presence of prosthetic wall, the fever more than 100.4 Fahrenheit degree. For the vascular, you have to see many things like Janvi lesion, something important. You have to remember that Janvi lesion is included in the vascular part. Okay, that will confuse you. For the immunological evidence, you have to remember the Osler nodes, Roth spot, and positive rheumatoid factor. The important thing is this: these 2 points, Osler nodes and Roth spot, is associated with vasculitis, infective endocarditis, vasculitis. Yeah, endocarditis associated with vasculitis. Okay, and the Roth spot is seen in the eye. Okay, you can remember by this that you love seeing in a rose. Okay, love seeing a rose. Okay, I will include this in the notes also. To remember Roth spot, you love seeing a rose. The Roth spot is seen in the eye. For the microbiological important one, this is positive blood culture for a microbiome consistent with infection not meeting the major criterion requirement. Imaging less than 3 months of cardiac surgery. This is important, and this was the question I think. And the physical examination can there is changes in the murmur. This is the new auscultation of regurgitation murmur when echocardiography is unavailable. This is the thing you have to remember, that there are one pathological criteria, that is short if the pathological criteria is met, or you have to go with the clinical criteria. The clinical criteria either go with two major, one major plus three minor or five minor. The major criteria include microbiological, MIS, miss, imaging, I, S for surgical. The important point is here 3 months of cardiac surgery, commonly causing two or more separate blood culture set, for the rarely three or more separate blood culture set. Okay, and the Roth spot is seen in the eye, and oscular nodes in the joints, main part of joints like the elbow joint, and these are the prominent part of the body. And Janvi lesion is a vascular lesion, ठीक है? It find in the leg or red color circular patches like this. Vascular. The profile axis of eye is indicated in these cases only, ठीक है? Like people with prosthetic wall, previous episode of infective endocarditis, there is post-cardiac transplant patient, unrepaired CHD patient, a repair CHD within 6 months. This is important, can be asked in the pediatric also. And in the pre-procedure prophylaxis, if someone is doing dental procedure or invasive procedure of respiratory tract like adenoctomy, tonsillectomy, or incision drainage of the respiratory mucosa, this is the important pre-procedure prophylaxis. What is the medication? Amoxicillin 2 gram oral, 30 to 60 minutes before procedure. Or if someone has penicillin allergy, then you have to go with azithromycin or cephalexin or clindamycin. If someone is unable to take the medicine only, you have to go with ampicillin IV or ceftriaxone IV, or in penicillin allergy, you have to do clindamycin 600 mg IV. The important point or the extras in this topic, you can remember the Jones criteria is for rheumatic heart disease. Remember this by heart. The Duke criteria is for the infective endocarditis, and the Jones criteria is the for rheumatic heart disease. Thank you.